Welcome to the deep dive. Today we're taking a close look at in vitro fertilization, or IVF, a technology that has brought so much hope and, well, so many families into being.
Exactly. And we're going to explore what IVF truly involves, the reasons people use it, how the process actually works step by step.
Right, and also things like success rates, which everyone wants to know about, potential complications, and maybe touch on some of the broader societal stuff too.
Yeah, absolutely. To do this, we've looked at quite a few different sources. We've got info from medical websites, a really comprehensive Wikipedia entry, a very personal account of someone's IVF journey.
And also discussions from an online community forum, which I found really insightful. It gives you that real-world perspective.
It really does. So our mission today, if you like, is to give you a clear, informative picture of IVF, sort of answer the common questions, highlight the key aspects for anyone curious about it.
Okay, so let's start at the beginning. What is IVF? The name itself, in vitro.
Right? In vitro, it's Latin, means in glass. Because literally the first fertilizations happened in lab glassware, like Petri dishes or test tubes.
Ah, okay, so not necessarily a test tube baby in a literal test tube.
Well, not grown in one, no.
Yeah.
But the fertilization part, yeah, outside the body, in the lab environment. That's the key contrast with in vivo fertilization, which just means fertilization happening inside the body, naturally.
Got it. And the history is quite fascinating too, isn't it? Everyone knows about Louise Brown in the UK in 1978.
They do, the first successful IVF birth, a huge milestone. But what's less known, maybe, is that just about 2 months later, another baby, Durga, was born in India using a method developed independently by Dr. Subhash Mukhopadhyay.
That's incredible. Why isn't that story more widely known?
Well, unfortunately, Dr. Mukhopadhyay faced a lot of skepticism back then. He didn't really get the recognition he deserved at the time for his work, which is, well, it's a shame. Shows how scientific breakthroughs aren't always immediately accepted.
A reminder that progress isn't always linear, I suppose?
Definitely not. And look at the impact now. By 2018, the estimate was something like 8 million children born worldwide thanks to IVF and similar technologies.
8 million. Wow. That really puts into perspective how significant this has become.
It's huge. It's transformed family building for so many people.
Okay, so that's the scene. But let's get into the why. Why do people turn to IVF? What are the main medical reasons?
Well, the biggest one, historically and still very common, is issues with the fallopian tubes in women. You know, the tubes are blocked or damaged. The egg and sperm just can't meet naturally. IVF gets around that completely.
Right, it bypasses the problem area. But it's not just female factors, is it?
Oh, absolutely not.
Mm-hmm.
Male infertility is a major reason, too. Things like low sperm count, or maybe the sperm don't swim very well, or issues with sperm shape.
And is that where techniques like ICSI come in? I've heard that term.
Exactly. ICSI stands for intracytoplasmic sperm injection. Sounds complex, but basically, instead of just putting the egg and sperm together in a dish and hoping for the best, the embryologist selects a single, healthy-looking sperm and injects it directly into the egg. It dramatically increases the chance of fertilization when there are sperm issues.
Okay, that makes sense. It's a very direct approach. What about situations where the infertility cause isn't clear?
Yeah, unexplained infertility. The NICE guidelines in the UK, for instance, suggest considering IVF if a couple hasn't conceived after, I think, 2 years of regular unprotected intercourse.
So after trying other things first?
Often, yes. Or if the cause just remains elusive, it becomes an option then. Also, sometimes women have issues with ovulation. They don't release eggs regularly.
And ovulation, right?
Correct. Doctors might try ovulation induction first, using medication to stimulate egg release. But if that doesn't work after a good number of cycles, say 7 to 12, then IVF might be the next step. It offers more control.
Okay, so it addresses a range of fertility challenges. Let's get into the actual how, the process itself. It seems like quite a journey.
It is. It's a multi-step process. Definitely requires commitment. The first main phase is usually ovarian hyperstimulation.
Okay, stimulating the ovaries. Why multiple eggs? Normally it's just one, right?
Right. In a natural cycle, usually just one egg matures.
Yeah.
But for IVF, the goal is to get multiple mature eggs because, well, not every egg will fertilize, and not every resulting embryo will develop properly. More eggs mean more chances, basically.
Increasing the odds makes sense. How do they do that?
Usually with hormone injections that stimulate the follicles in the ovaries. Those are the little sacs that contain the eggs to grow and mature multiple eggs.
And then once the eggs are ready, there's a trigger.
Exactly. Once the follicles reach the right size, there's a final maturation step triggered by an injection. Often it's HCG, human chorionic gonadotropin, which mimics the natural hormone surge before ovulation. You might hear it called the trigger shot.
And the timing of that shot is critical, I read.
Absolutely critical. It sets the clock for egg retrieval. The retrieval is usually scheduled for about 34 to 36 hours after the trigger, just before the body would naturally ovulate.
You mentioned HCG, but sometimes they use something else, a GnRH agonist.
Yes, that's an alternative. Using a GnRH agonist trigger can significantly lower the risk of something called ovarian hyperstimulation syndrome, or OHSS, which is a potential complication we should talk about.
Okay, so it's a safety measure.
It can be, yeah. The trade-off is sometimes it might slightly lower pregnancy rates if the embryos are transferred in that same cycle, a fresh transfer. So often if an agonist trigger is used, the clinic might recommend freezing all the embryos and transferring them later in a separate cycle.
Right, managing risks versus maximizing immediate chances. So, trigger shot done, timing set. Next is getting the eggs out.
Egg retrieval, yes. It's typically done using transvaginal ultrasound aspiration.
Sounds involved.
It is a medical procedure. Guided by ultrasound, a thin needle is passed through the vaginal wall into the ovarian follicles, and the fluid containing the eggs is gently suctioned out.
Ouch. Or is there anesthesia?
Oh, yes, definitely. It's usually done under conscious sedation or sometimes general anesthesia, so the patient is comfortable. The procedure itself is relatively quick, maybe 20 to 40 minutes.
And how many eggs do they typically get?
It varies a lot, but maybe somewhere between 10 and 30 eggs is common. The fluid goes straight to the embryology lab next door.
Okay, eggs collected. Now, the in vitro part really happens in the lab. Fertilization.
Correct. The eggs are prepared, the sperm sample is prepared, and then they're brought together. In standard IVF, they're put in a dish together to let fertilization happen naturally, so to speak.
And if it's ICSI?
Then, as we said, the embryologist takes over, injecting one sperm into each mature egg.
Right. Okay, so hopefully fertilization occurs. Then what? Do they grow them for a bit?
Yes, that's embryo culture. The fertilized eggs, now embryos are kept in special incubators with carefully controlled conditions, mimicking the womb, for several days.
How long do they culture them?
It can be until the cleavage stage, which is around day 2 to 4 after fertilization, when the embryo is just a few cells. Or, increasingly common, is culturing them longer to the blastocyst stage.
Blastocyst, that's day 5 or 6.
Usually day 5 or 6, yeah. It's a more developed stage.
And I gather there's some debate about which stage is better for transfer.
There is. Culturing to blastocyst allows for a kind of natural selection in the lab. Only the more robust embryos tend to make it that far. So transferring a blastocyst might give a higher chance of pregnancy per transfer.
But there's always a but, isn't there?
The but is that fewer embryos might make it to the blastocyst stage overall. So you might end up with fewer embryos to transfer or freeze compared to transferring earlier at the cleavage stage.
Ah, a trade-off. Fewer embryos potentially, but maybe a better chance with the ones you have.
Sort of, yeah. And some studies, though it needs more research, have hinted at maybe a very slight increase in risks like preterm birth with blastocyst culture. So it's a discussion to have with the clinic.
Okay, so embryos are growing. How do they decide which one or ones to put back?
Embryo selection. First, they look at them under the microscope, the morphology. How do the cells look? Are they dividing evenly? Is there much fragmentation?
Just based on appearance?
Primarily, yes, for morphology. But increasingly, there's also genetic testing, PGT, pre-implantation genetic testing. This used to be split into PGS, screening, and PGD, diagnosis, now often just called PGT.
PGT, what does that tell them?
It can tell them a few things. PGTA, for aneuploidy, checks if the embryo has the normal number of chromosomes. Abnormal chromosome numbers are a major cause of implantation failure or miscarriage.
Okay, screening for viability.
Exactly. Then there's PGTM for monogenic or single gene defects. This is used if parents are known carriers of a specific inherited disease, like cystic fibrosis or Huntington's. It tests the embryos for that specific condition.
So you can avoid passing on a known genetic disease.
Precisely. And there's also PGPSR for structural rearrangements if a parent has a known chromosome rearrangement. The goal of all PGT is to select the embryo most likely to lead to a healthy pregnancy.
Makes sense. So selection done. Then the transfer itself.
Yes, the embryo transfer. The selected embryos are loaded into a very thin, flexible tube, a catheter, and that catheter is carefully passed through the cervix into the uterus, and the embryo is gently deposited there.
How many do they usually transfer? I know this varies a lot by country and circumstance.
It really does. The trend now, strongly encouraged in places like the UK, Canada, Australia, is towards single embryo transfer, SATIT, especially for younger women with good quality embryos.
To avoid multiples.
Exactly. Multiple pregnancies, twins, triplets carry significantly higher risks for both the mother and the babies. Prematurity, low birth weight, complications during pregnancy. The goal is usually one healthy baby at a time.
So regulations or guidelines often push for set.
Yes, many countries have guidelines or even regulations limiting the number transferred based on age and embryo quality. In the U.S., while there aren't strict laws everywhere, professional guidelines strongly recommend minimizing multiples, tailoring the number transferred to the individual.
Okay. Embryo is in. Is that it for the cycle?
Almost. The last step is luteal phase support. After the transfer, the woman usually takes medication, typically progesterone.
Why progesterone?
Progesterone helps prepare and support the uterine lining, making it more receptive for the embryo to implant and helping to maintain the early pregnancy. The stimulation process can sometimes affect natural progesterone production.
Got it. So it really is a carefully orchestrated process. Now, the big question, success rates. What do the numbers look like?
Yeah, this is crucial. Success is usually measured as the live birth rate per cycle started, or per embryo transfer. That's the key metric, a baby going home.
And rates have improved over time.
Definitely. Techniques have gotten much better. Our sources mentioned Australia, for example, saw live birth rates per transfer increase quite a bit between 2005 and 2010, even while transferring fewer embryos on average. That's progress.
What about more recent figures, say from the U.S.?
Okay, data from SART for 2021 gives a good snapshot. For women under 35 using their own eggs, the average live birth rate per cycle was around 54%.
That sounds pretty good.
It is, but it drops significantly with age. For women 35-37, it was about 40.5%, then 38-40, down to 26%. Ages 41-42, about 13.3%. And over 42, it drops to around 4%.
Wow, age is clearly a massive factor. That's quite stark.
It's the single biggest predictor, really. Egg quality declines significantly with age. We also saw Canadian data from 2006 showing a similar pattern overall, about 27% live birth rate per cycle then, but much higher for younger women.
And remember, these are averages. Clinic results can vary.
Absolutely. And clinics might specialize or have different patient populations. It's complex, but age is consistently key.
Beyond age, what else influences success? You mentioned predictors.
Yes, several things. How long someone's been infertile matters. Then there are markers of ovarian reserve, how many eggs might be left, blood tests like AMH, anti-Müllerian hormone, and FSH, plus ultrasound scans counting antral follicles.
So basically assessing the egg supply and quality potential.
Pretty much. A higher AMH, more follicles, more eggs retrieved, those generally correlate with better chances.
What about the male side?
Sperm health is vital too. Things like sperm DNA fragmentation damage to the sperm's genetic material can negatively impact outcomes.
And the uterus itself, where the embryo implants.
Endometrial receptivity is key. Doctors look at the uterine lining thickness on ultrasound, generally wanted over 7 millimeters, and its pattern. A triple line pattern is considered good.
Okay. Lifestyle factors, do they make a difference?
They definitely can. Smoking is a big negative, significantly lowers live birth chances, increases miscarriage risk. BMI outside the healthy range, roughly 20-27, is also linked to lower success.
So maintaining a healthy lifestyle helps.
It seems so. Moderate alcohol and caffeine intake might be better than high intake. On the positive side, having had a previous successful pregnancy generally improves odds. And obviously, the number and quality of the embryos transferred are huge factors.
What about things like aspirin or acupuncture? People often ask about those.
Yeah, the evidence there is, well, not strong. Our sources indicate large reviews haven't found clear proof that routine aspirin use improves IVF outcomes. Same for acupuncture meta-analyses don't show a consistent benefit for live birth rates across the board.
So maybe helpful for well-being, but not a proven boost for success rates.
That seems to be the consensus from the large studies, yeah. Lifestyle advice before treatment also didn't show strong evidence for improving live birth rates in one review. The core biological factors seem most critical.
Okay, so success is complex, age is key, but many factors play a part. Let's shift to potential complications or health effects. What are the main risks?
The biggest one, related to transferring multiple embryos, is multiple births, twins, triplets, etc.
Which we said carries risks.
Exactly. High risk of pregnancy loss, premature birth, low birth weight, neonatal complications, more risks for the mother. It's why single embryo transfer is increasingly the standard where possible.
Got it. Anything else? I saw a note about sex ratio.
Oh yeah, that's interesting. Some studies found slight shifts. ICSI seems linked to slightly more female births, while blastocyst transfer might be linked to slightly more male births. Standard cleavage stage transfer is usually closer to the natural 50-50-ish ratio.
Huh. Any idea why?
Not entirely clear. Maybe subtle differences in how male versus female embryos develop or survive under specific lab conditions. It's subtle, though.
What about infectious disease screening?
Yes, that's standard practice. In the U.S., for instance, anyone receiving donor embryos has mandatory FDA screening. And generally, both partners are screened for various infections at the start of the process.
And risks for the person providing the eggs?
That's
The retrieval process?
There's a slightly increased relative risk of blood clots like DVT or pulmonary embolism in the first trimester after IVF compared to natural conception. Long-term cardiovascular risks don't seem clearly linked in studies so far, though.
Okay. And one thing, can people get pregnant naturally after doing IVF?
Yes, absolutely. It happens. Sometimes even after unsuccessful IVF or after having an IVF baby. Underlying fertility issues might still be there, but spontaneous pregnancy isn't impossible for some.
Right. Now, a really sensitive topic, the health of the babies. Are there increased risks of birth defects?
This has been looked at a lot. An older review from 2013 did suggest a slightly higher relative risk compared to natural conception. Some specific things like certain heart defects were mentioned in some studies.
Yeah.
But a more recent, very large study tried to untangle this. When they adjusted for parental factors like the mother's age, smoking, the very fact of having infertility, the increased risk linked to standard IVF itself basically disappeared. It wasn't statistically significant anymore.
So it might be more related to the underlying reasons people need IVF or parental age.
That seems likely. The infertility itself or the age profile of many IVF patients might be the contributing factor. However, that same large study did still find a slight residual increased risk associated specifically with ICSI, even after adjustments.
ICSI again. Why might that be?
The researchers speculated it might relate to the underlying severe male infertility factors that often lead to using ICSI in the first place. But it's important context. The absolute risk increase is small, and the vast majority of IVF and ICSI babies are perfectly healthy.
That's really crucial context. Okay, so we've covered the what, why, how, success, and risks. Let's broaden out to the societal and ethical side. This is where it gets really complex, doesn't it?
It really does. IVF touches on so many deep societal questions. For instance, the genetic testing we talked about, PGT.
Right, PGTA and PGTN.
Exactly. While it aims for healthy pregnancies, it also raises concerns for some about designer babies, potential for eugenics, and equitable access who can afford this testing.
Yeah, those are big ethical discussions. I also saw criticisms mentioned about the IVF industry itself sometimes.
Yes, occasional criticisms regarding how infertility prevalence is sometimes portrayed, or concerns about commercial pressures. It's a field with both profound benefits and business aspects.
And IVF has changed possibilities around age and parenthood, too.
Hugely. Using donor eggs, women can become pregnant after menopause. This raises philosophical questions about genetic versus gestational parenthood, doesn't it?
It does. And it's opened doors for different family structures, too.
Absolutely. Increasing use by same-sex couples, single parents, unmarried parents. Organizations like the American Society for Reproductive Medicine, ASRM, have statements supporting access, and studies generally show children thrive in these families just as well.
Are there legal protections in place for these families?
It varies. Some places, like California, have specific legal protections for LGBTQ+ individuals accessing assisted reproduction. But it's not uniform everywhere.
What about transgender individuals? Can they use IVF?
Yes, they can, though the sources note there's less research here, and individuals might face challenges navigating medical systems or societal biases like potential gender dysphoria during treatment or being misgendered.
But the options exist, like using frozen eggs or sperm collected before transition.
Exactly. Options like using cryopreserved gametes or donor gametes or surrogacy are possibilities for transgender men and women wanting to build families biologically.
And access for people with disabilities, another area with potential barriers.
Definitely. Concerns about potential biases, assumptions about capability, and physical or structural barriers within the healthcare system can make accessing fertility treatments, including IVF, more challenging for disabled individuals.
It really highlights the need for equitable access. Speaking of access, how does availability and regulation look globally? It seems quite varied.
Extremely varied. Australia, for instance, generally prohibits using IVF for non-medical sex selection. Canada has varying levels of public funding province by province. China has complex policies regulating RT while also discouraging abortions. India now has more regulations on RT clinics.
What about somewhere like Israel?
Israel is known for having very strong state support and funding for IVF, making it highly accessible there.
And the UK and US?
In the UK, an NHS funding exists but can be limited. With postcode lotteries and varying criteria, so many pay privately. In the US, insurance coverage is very patchy. Some states mandate some coverage, many don't. Cost is a huge barrier for many Americans.
And the US has seen some political controversy recently, too, around embryo status.
Yes, definitely. The Alabama Supreme Court ruling in early 2024, which treated frozen embryos as legal children, caused huge disruption and fear, leading to temporary pauses in IVF services there.
But they passed legislation to protect IVF after that.
They did pass state-level legislation quickly to provide some legal protection for IVF providers in Alabama. And there have been ongoing discussions and attempts at federal legislation to protect or regulate IVF access nationally, highlighting how politically charged the issue can be, particularly around the legal and moral status of embryos.
Right. And didn't the previous administration also touch on IVF costs?
Yes, there was mention of an executive order by President Trump aimed at exploring ways to lower IVF costs, indicating it's an issue with bipartisan awareness, even if the approaches differ.
It's complex. What about religious viewpoints?
Also very diverse. Within Christianity, views range from acceptance to strong objections, often related to embryo status or third-party gamete donation. Islam generally permits IVF for married couples using their own gametes, but typically prohibits third-party donors or surrogacy. Judaism has internal debates, particularly within Orthodoxy, but generally finds ways to permit IVF.
And culturally? Any interesting aspects?
Yeah, the sources mention things like the tradition of fostering being very important in parts of sub-Saharan Africa, offering different perspectives on family building. And in the U.S. infertility community, the pineapple has oddly become a symbol of hope and solidarity during treatment.
A pineapple. Okay. Any findings on IVF parents themselves?
Interestingly, some studies suggest IVF parents, perhaps because of the difficult journey, may show even greater warmth and emotional involvement with their children compared to parents who conceived naturally.
That's lovely. But the journey itself, the cost, is a huge barrier.
Massive. The financial burden is often the biggest hurdle, limiting access for many who could benefit.
And the emotional toll. Our personal account and forum sources really highlighted that.
Immensely. The constant cycle of hope and disappointment, the physical demands of treatment, the anxiety of the 2-week wait after transfer.
That wait sounds excruciating.
It really does. And the grief of failed cycles or miscarriage after finally getting pregnant. Body image issues from hormones, the strain on relationships, the incredibly difficult question of when or if to stop trying.
The forum discussions also touched on some deeper ethical thoughts, even antinatalist views sometimes.
Yes, some people grapple with those big questions amidst the struggle. Is bringing a child into the world always the right thing? It shows the depth of reflection it prompts. And overwhelmingly, the need for support from partners, family, friends, support groups comes through loud and clear.
It's clearly a journey that takes a huge physical, emotional, and often financial toll.
Absolutely. It requires immense resilience.
So to wrap this up, IVF is, well, an incredible scientific advancement addressing infertility, involving a complex series of steps. Success varies hugely, influenced by age and many other factors.
Right, and there are potential physical and significant emotional challenges, alongside this really intricate web of societal, ethical, and legal considerations that are constantly evolving.
It truly offers a path to parenthood for millions, but it's definitely not a simple path, and it raises important questions for us all.
It does. It represents hope, science, and complex human choices all rolled into one.
So maybe a final thought for you, our listener, considering how fast reproductive science is moving and how societal norms are shifting, what do you think are the most vital conversations we need to have about the future of these technologies and ensuring access is fair and equitable for everyone? Something to ponder. Thanks for joining us on The Deep Dive.